Good afternoon. Today I would like talk about other possibility and alternative method for treatment wide neck aneurysm and fusiform aneurysm. All know it's very difficult aneurysm for treatment, and today we listen many presentation with flow diverter. And I would like show two methods for effective method for treatment of fusiform and wide neck aneurysm. And I would like show natural bypass. What is natural bypass? It's collateral flow from gut. So it's not surgically bypass. It's absolutely natural. Collateral flow. So we today see many information about flow diverter, about intracranial stent protect wide neck aneurysm with balloon protect, and I would like show what happened with these many perforator of basilar and middle cerebral artery after put after implantate of flow diverter. We know patient have many possibility from gut, it's collateral flow, and I would like show many problem we wait from flow diverter, balloon, and intracranial stent. For example, balloon cannot be used in the case of Willis circle, hypoaplasia, and angiospasm. Intracranial stent does not protect the aneurysm's wide neck. Coil can migrate into the parent vessel, possible recanalization of aneurysm. Stent make reoperation more difficult. Flow diverter is contraindicated in cases with subarachnoid hemorrhage. Risk of thromboembolic stroke and vessel occlusion, risk of arterial dissection and rupture, risk of traumatic angiospasm, vasculitis, technical difficulties, for example, in coiling and kinking of internal of carotid artery, risk of perforated occlusion, unexpected result. Colleague asked for me, Stefan, after flow diverter treatment, you close aneurysm. I said I put flow diverter, but okay, aneurysm work or not? I said work, but maybe close tomorrow, maybe 1 month later, maybe 1 year later. Spontaneous bleeding after the stenting flow diverter, stent migration into the giant aneurysm cavity, long-term antiplatelet therapy, expensive device. So you know we have many problems with this device, and catastrophic experience of aneurysm treated with flow diverter, possible massive bleeding and very massive stroke. And I would like show 366 patients who had wide neck aneurysm. 310 aneurysms were occluded without supporting device. 56 aneurysms were occluded with stent or balloon protection of the parent vessel. Reoperation in 23 cases, and we have complication in 18 cases. The arteries originate from the mast of the wide neck aneurysms sac. The radical occlusion is not possible because of the pathological vessel wall structure at the junction of the artery and the aneurysm. No rebleeding. In weak cases, we don't have rebleeding occurred in the subtotally closed aneurysm during 7-year follow-up. And wide neck aneurysm patients are controlled serially by DSA and MRI. So first cases I would like show its method with two microcatheter. You can see left side wide neck middle cerebral artery bifurcation aneurysm. I put in aneurysm sac two microcatheter, and we have a very interesting coil. This is matrix coil. Why this matrix coil is good for treated is wide neck aneurysm, but the best size we have 15 centimeter long and 2 millimeter size coil, and 3 millimeter and 20 centimeter long of this coil. And we put two coil in aneurysm sac, and you can see this procedure of occlusion aneurysm. It's very simple and very effective. And after put of two coil, I detach only one coil, and second coil protect first coil from migrate from aneurysm sac. After I put third coil and detach second coil, and next coil is, and aneurysm slowly possible remodeling occlusion of this is wide neck aneurysm. And finally, we remove catheter and two catheter, and you can see result of occlusion of this wide neck aneurysm. It's very simple and effective, and you can see this after rupture very wide neck aneurysm with serious angiospasm. With two microcatheter technique, I have very good result after occlusion with coil this aneurysm, and 3 months later you can see occlusion of aneurysm, and you don't see of angiospasm. Very wide neck aneurysm treated with two catheter method. And this same rupture middle cerebral artery aneurysm with very wide neck, and you can see very good result after treatment. But not all very good. For example, this rupture aneurysm I very good close with two microcatheter technique. You can see result. I'm very happy. But 3 months later we have recidive this aneurysm, and the aneurysm was refiled even after the 4 procedure. And this is last angiography show dilatate of aneurysm sac. What possible do in this situation? I think the best treatment in this situation is natural bypass. I do test occlusion of middle cerebral artery and look of collateral flow, and very small coil, one coil I close middle cerebral artery. This is operation I do without narcose. Patient before operation don't have not vaccinated. And I finally occluded of middle cerebral artery, and you can see very good leptomeningeal anastomose. Aneurysm is closed. And what in this situation very important, this aneurysm not have recidive, impossible rupture. It's very simple and very good work. 4 months later, the patient had no any signs, and you can see not retrograde flow. This short arterial anastomose, middle cerebral and middle cerebral artery, and you can see anterograde flow in aneurysm. The next patient I would like to show this very difficult fenestrated aneurysm after bleeding, and this branch is frontal branch, and you can see lenticulostrial thalamic perforator. This is test occlusion, a distal part of middle cerebral artery, and we look this situation. The next step is magnification and technique of operation. The next step is test occlusion of M1, and we look leptomeningeal anastomose. This is superselective angiography, show the perforator, and the last step, occlusion, aneurysm, distal part from perforator, and this patient don't have symptom. And last cases, it's a fusiform middle cerebral artery aneurysm. It is very difficult dissected aneurysm, and interesting test occlusion show anastomose, aneurysm, and M1 middle cerebral artery. And impossible close only proximal part of aneurysm. After successful occlusion of aneurysm, you can see very good collateral flow, and aneurysm not work. And the control angiography show it is small moya and very good anterograd flow in middle cerebral artery. So conclusion, wide neck aneurysm with complicated structure can be occluded by the endovascular technique. Without surgical bypass. In most cases, 86%, it don't need any supporting device. The result of subtotal occlusion of wide neck aneurysm is much better than efforts to occlude it completely, because it may be the cause of the parent vessel occlusion. Thank you very much.
Any question for the audience?
So in the double catheter, the first coil that you use in is a basket coil, or you use the small coil together?
So this is two small coil, and I mix one and second coil. And why it's very important, but first catheter I don't detach, I detach second coil, yes? And first coil not impossible migrate coil in parent vessel. After I put third coil and detach first coil. Its technique, it's possible very good remodeling of wide neck and very difficult form aneurysm occlusion. And very, very simple.
I think thank you for the approach that you show us. I think the testing part is the one I want to ask you, because the ability, what we learned with flow diversion, and is that it's very hard to predict with angioplasty or with a balloon occlusion the outcome of the collaterals. You know immediately if you block the artery that collaterals exist. But interesting, sometimes patients fail balloon test occlusion, but if you were to still have flow diversion, it seems that sometimes you may need to support the blood pressure, but over time there is development of the necessary collateral. So some cases that would say you have to go to bypass because you do balloon test occlusion and you fail right away. Those cases we're seeing sometimes you can support the blood pressure but decrease the head pressure going because you're flow diverting or jailing an artery. And I think this is the challenge. This is a new concept that we don't know the long term what's going to happen with these cases that are flow diverted, and they, especially if they fail balloon test occlusion and you have to support with blood pressure management, ICU stay a little longer. Some, I think Jivan and Naji showed some perfusion studies showing that there's a difference in perfusion for a long time. Long term, we don't know what that does, but it's a new concept. And in this case, you have to be sure the balloon test occlusion passes before you do, right? There's no way around that.
Interesting. After start of thrombectomy, me see many cases. I think it's 70% patient have good leptomeningeal anastomosis. It's interesting. In all time, I don't believe this, and it's occlusion of middle cerebral artery. It's very danger. But now, why now we know what happened? Why patient have plagia and paresis, but M1 middle cerebral artery occlusion close of perforator, and very good work of collateral flow, but patient have symptom. In after very good test occlusion of middle cerebral artery branch and possible other, it possible very good treated this aneurysm, and patient leave without clopidogrel. This aneurysm, it's nothing not open. It's absolutely stable and very simple for treated, and it's not problem with work. Leptomeningeal anastomosis, a possible anastomosis, short arterial anastomosis. In flow diverter, we have big problem. We don't know prognosis. What happened after put of flow diverter? Artery occlusion, aneurysm occlusion, aneurysm residue. So we don't know what happened 1 year later. So we have, after very good treatment with flow diverter aneurysm, 1 year later, close of internal carotid artery. So we know many this situation. Okay, thank you.